All right, today we're going to build a high-yield toolkit for what can be one of the most confusing areas in all of radiology, sinonasal and skull base imaging. This is your game plan, your guide to looking at these scans and actually knowing what you're doing. So let's get right into it.
You know the feeling, right? We've all been there. It's the middle of a long call, and this monster case pops up. The sinuses are totally whited out, the anatomy looks like a maze, and the list of what it could be is a mile long. This whole explainer is designed to give you a clear, step-by-step approach so you never feel that way again. Okay, first things first, your most important tool, before you even think about a diagnosis, is picking the right study for the question you're trying to answer. The whole CT versus MRI decision, it's not random. It's absolutely fundamental. So here's the bottom line, and you really want to burn this into your brain. Think of CT as your go-to for bone and infection. It is hands down the best for seeing if an aggressive infection is eating through bone, especially into the front of the eye. But, and this is a big but, the second you're worried about a tumor, or if the disease is sneaking towards the back of the eye, like the orbital apex or the cavernous sinus, you have to get an MRI. It is absolutely mandatory. You need that amazing soft tissue detail to see a tumor crawling along a nerve or invading deep into the skull base.
All right, so you've picked the right scan. Now let's grab our second tool, which is all about decoding infection and inflammation. I mean, this is the bread and butter of sinus imaging, but telling all the different patterns apart, that's where it gets tough. Let's break it down. Fungal sinusitis is a huge one, and it comes in two totally different flavors. First, you've got the good kind, allergic fungal sinusitis. Look at the patient type. They have a normal immune system. On CT, the key is that the gunk in the sinus is hyperdense. It's bright white centrally. Now on the other side, you have the bad one, invasive fungal sinusitis. This is a 5-alarm fire in a patient who's immunocompromised. And here's the critical part. On CT, the sinus contents are not hyperdense. The real clue is stranding in the fat around the sinus. That means it's breaking out. And on MRI, it gets even scarier. That fungus can kill the sinus lining, making it necrotic, so it stops enhancing. That is a terrible, terrible sign.
So you might be wondering, why on earth is that allergic fungus so dark on a T2-weighted MRI? Sometimes it's so dark it looks just like air. Well, this analogy is perfect. Imagine a suitcase that's been packed so tightly with dense proteins and heavy metals that there is literally no room left for anything else. MRI sees water moving around, right? In that fungus, there's no room for water to move, so no signal. It just appears black.
Okay, now for your run-of-the-mill chronic inflammation. Think of it like a plumbing problem. The pattern of disease just tells you where the drain is clogged. The most common one you'll see is the infundibular pattern. The blockage is right at the opening of the maxillary sinus, so only that one sinus is affected. But if the clog is a little higher up, at the osteomedial unit, you get this bigger backup, this more widespread pattern that involves the maxillary, frontal, and ethmoid sinuses all on the same side.
Now, two really common benign things can fill up the sinuses and cause mass effect, but they do it in very different ways. A mucocele is basically a trapped, obstructed sinus that just slowly blows up like a balloon. The key word is expansion. It causes smooth, outward bowing of the bony walls. Sinus polyposis, on the other hand, it causes bony remodeling and erosion. The classic giveaway is seeing the drainage pathways, the infundibula, get widened as the polyps literally push their way through. So remember, expansion versus remodeling. It's a huge clue.
All right, let's switch gears and pull out our third tool, how to tackle tumors. I know these can seem really intimidating, but a lot of them have these classic, almost Aunt Minnie appearances that can point you right to the answer if you know what to look for. If you see this shape, this very specific shape, right at the skull base, your brain should immediately light up with one particular diagnosis. Let's see what it is.
And there it is, osteonasoblastoma. It comes from the olfactory cells way up high in the nasal vault, right at the cribriform plate. And it does this classic thing where it grows up into the brain and down into the sinuses, creating that perfect dumbbell shape with a tight little waist where it squeezes through the bone. Oh, and here's a little pro tip. Look for cysts inside the part of the tumor that's in the brain. That is a massive clue.
Oh man, this one is a classic. This clinical history is so specific, it's practically the diagnosis. If you get this on a test or in real life, you're already 99% of the way there.
Yep, of course, it's the juvenile nasal angiofibroma, or JNA. The name tells you almost the whole story. It's in a juvenile, an adolescent male, and it's an angiofibroma, which means it is packed with blood vessels. It has a classic starting point right at the sphenopalatine foramen, and when you give contrast, this thing will light up like a light bulb.
Okay, next up is the inverted papilloma. This one is tricky. It's a bit of a wolf in sheep's clothing. It's got some classic features, for sure. It usually grows from the lateral wall of the nasal cavity. On MRI, it creates this very unique, convoluted pattern that we call cerebriform. It literally looks like the surface of a brain. And on CT, you can sometimes see a little spot of thickened bone right where it started. But there's a catch. 10%. Just burn that number into your memory. It is one of the single most important high-yield facts about this particular tumor.
And here's why that number is so critical. A full 10% of these things, which otherwise look pretty benign, are actually hiding an aggressive squamous cell carcinoma inside them. So whenever you think you see an inverted papilloma, your job is not done. You have to meticulously search that scan for any little area that looks more aggressive or suspicious.
Speaking of which, let's look at the two big bads of sinusinal cancer. Squamous cell carcinoma, or SCC, is the most common by far. It loves the maxillary sinus, and on imaging, it can sometimes enhance a little less than other tumors. Then there's SNUC, sinonasal undifferentiated carcinoma. Think of this as the monster version. It's just an incredibly aggressive, ugly lesion that's often huge by the time it's found, and it tends to prefer the ethmoid sinuses.
Okay, for our final tool, let's look at something a little different. These are the cases where the problem isn't the stuff inside the sinus, but the actual bones of the skull base.
With these two, the patient's age is your absolute best friend. It's the key. If you see an expanded, hazy, ground glass-looking bone lesion in a patient who's young, under 30, you are looking at fibrous dysplasia. If you see a thickened, bizarre-looking skull in a patient who is older, over 60, you have to be thinking Paget's disease. Paget has this classic early phase, the lytic phase, called Osteolysis Circumscripta, which looks like a big, clean hole in the skull before it gets all thick and sclerotic.
And Paget's disease is no joke. It can cause some really serious problems. The most common complication is actually deafness, because the abnormal bone can overgrow the delicate structures of the inner ear. It can also pinch cranial nerves, cause the skull base to sag and compress the brainstem. And there's a small but very real risk, about 1%, of it transforming into a deadly bone cancer, an osteosarcoma.
Just hopping back to fibrous dysplasia for a second, if you see it in more than one bone, you have to think about McCune-Albright syndrome. This is pure boards fodder, so lock it in. The classic triad is multifocal fibrous dysplasia, those café au lait skin spots, and endocrine issues like precocious puberty. It's a must-know.
Okay, you've made it through a ton of material. Let's lock in one final, absolutely critical point with a quick pop quiz. You ready?
Okay, picture this. You've got a big, destructive mass at the clevis, right in the center of the skull base. They can look almost identical. What is the one rule, the one feature that will tell you which one it is almost every single time?
The answer is just one word 3 times. Location, location, location. It's that simple. Chordomas come from notochord remnants, and the notochord is a perfectly midline structure, so chordomas are midline. Chondrosarcomas come from cartilage, usually at the petrocleval fissure, which is off midline, so chondrosarcomas are off midline. When you're stuck between those two, that simple rule will give you the answer. Remember these tools, and I promise you'll have a powerful system to